Hello, we are Group 4, and our presentation is over health inequity among Medicaid-insured patients and uninsured patients. Throughout our presentation, keep in mind our three most important objectives. Number 1, the difference in care is noticeable between government-insured and uninsured patients. Number 2, the difference in quality among these two groups is affected politically, economically, socially, and technologically. And 3, the key to eliminating or closing the gap in quality of care starts with education and a key. Medicaid gives access for lower socioeconomic status individuals to health care, but there is a high risk concerning federal oversight and regulations of the program. A patient with Medicaid will have a very different experience at a doctor's office or a hospital than a patient with no insurance, from the general office attitudes to the excessive testing or lack thereof, and from the amount of time spent with the provider. These differences influence the relationship that is built with the provider and can severely impact a person's morbidity.
Our logical module includes resource input, activity strategies, outcomes, and impact statement. Our target community will live healthier lifestyle and even decrease health disparities among lower socioeconomic status individuals.
To start off the PEST analysis, we'll look at how our issue is impacted politically. Since Medicaid is a government health insurance, many people draft and have input into what can be covered, who is covered, and when Medicaid-insured families will be covered. Not all who apply for Medicaid are approved, since a qualification is income. Those who overqualify but do not receive insurance through their company or are self-employed are left uninsured despite still being classified as a low-income earner, just as Medicaid-insured people are. Economically, healthcare providers who accept Medicaid-insured patients pay a tax to the state in which they reside. This tax is supposed to help the state increase funds for government insurance, since the federal medical assistance percentage is based on a matching principle, meaning the federal government will match the funds the state accumulates for Medicaid. While this tax sounds daunting for medical professionals, the funds generated both in-state and federally increase jobs, as these funds go toward programs that need positions filled. From a social standpoint, the differences are noticeable in behavior and demeanor by healthcare providers and staff. Most noticeably in the movie Something the Lord Made, once the physician was aware that the family does not have any health insurance, he crosses off tests and orders he had anticipated to perform for the patient, explaining that all the tests are too expensive for them and that they should just say their last goodbyes to their child. This can be compared to a patient with Medicaid, where physicians know tests and orders will be covered, and thus take advantage of the system and create an abundance of lab tests, scans, and more for the patients with Medicaid. According to the U.S. Census Bureau of 2015, only 75% owned a laptop or desktop computer, and 74% owned a smartphone. But many healthcare offices are moving forward with online patient portals to communicate and set up appointments with healthcare providers, despite some individuals not having access to Wi-Fi, computers, or smartphones. Even when a patient has access to the online portal, tech literacy can be a barrier from utilizing the app, which leads to a barrier in them receiving care. Our initiative is to suggest procedure guidelines that recommend specific orders for that diagnosis or symptom logged. This will give equal access to a doctor's time, which leads to respect. All issues will be addressed and all questions answered, basically foster open communication. Creating guidelines will also avoid unnecessary testing on Medicaid patients, which will increase trust and limits pain and suffering from the patients. Both Medicaid insured and uninsured patients will receive the same sense of urgency. For diagnostic procedures, they'll be scheduled and reviewed quickly, and regardless of whether or not the office will get paid immediately through the state with Medicaid or in several months through a cash paying payment plan. And because of this, will lead to increased adherence to treatment plans, increased follow-up appointments, checkups, increased communication with medical staff, lower morbidity rates, and just lower mortality rates too.
Our budget includes a total of $257,000, which includes salary for personnel, public health advocates, project manager, marketing director, and general staff. It also includes travel, equipment, supplies, and other expenses.
A potential funder includes the Texas Health and Human Services, This organization provides grants directly to states, then provided to those who are eligible to receive those funds. This agency will assist with this initiative to ensure that proper funding can be granted towards Medicaid programs to help those in need. Lastly, the Center on Budget and Policy Priorities is an institute that focuses on serving Medicaid recipients and ensuring that proper coverage is met. They also focus on preventing proposals that affect Medicaid programs from imposing costs and slashing benefits on the vulnerable population. Change within policies is normal and occurs often, so partnering with the CBPP will allow Medicaid programs to have a support system.
Our first recommendation Our first recommendation is to rethink benefit design to improve medication adherence and reduce health disparities among minorities and people with low socioeconomic status. This can include review boards to review diagnostic testing prior to orders being sent, allotting enough time for patient to ask as many questions as needed without the physician or patient feeling pressured for time, which is at least 30 minutes, and addressing prescription drug coverage. The individuals who do not qualify for low income and become a part of beneficiaries subside face gaps in their drug prescription coverage. This gap is also known as donut hole, which results in lower adherence to medical prescribed to treat acute and chronic diseases and various other health problems.
Our second recommendation Our second recommendation is for the physicians and other healthcare providers to be able to have information sessions with public health professionals. Information sessions should provide training to increase cultural awareness, knowledge, and skills. Another thing that can be incorporated in these training sessions would be how to better communicate with different groups of populations depending on their language or cultural background. The information sessions will also incorporate culture specific attitudes and values into health promotion tools.
The third recommendation is The third recommendation is for government agencies, public health departments, and community organizations create partnerships to take action and provide educational programs for low-income individuals, vulnerable populations, and those who are interested in applying to be eligible for Medicaid. These organizations can create educational programs online or in person to explain what Medicaid entails and the process for applying it. Providers, social workers, and healthcare workers can assist individuals in the process and have a role in helping where and how to find programs that may assist them. Participation between government organizations and local communities can help make a difference in vulnerable and low income societies and achieve greater health outcomes.